I'm glad to have this opportunity to speak to you today. My name is Arata and I belong to the Department of Orthopedic Surgery at Sapporo Medical University. Today, I'd like to talk about the evaluation of micromotion, including the alignment of hip prostheses. The authors have no financial conflicts of interest to disclose concerning the presentation. Introduction. Evaluating micromotion and femoral bone reaction is essential to obtain long-term results with cementless stem prosthesis after total hip arthroplasty. Concerning femoral bone reaction, the standard stem may carry the risk of long-term fixation due to decreased bone density in the proximal femur. Therefore, short stems have recently attracted attention as a means of reducing bone density loss in the proximal femur after TJ. Because cementless short stems are placed proximally where the medullary cavity is wide, they come in various shapes and are installed in various ways. However, there are no clear standards for how the stem should be inserted to provide stability regarding alignment and constant side with the femur. The purpose of this study was to evaluate the initial fixation of cementless short stem depending on the alignment and the site of contact with the femur. Patients who underwent THU with the anterolateral approach in our department from April 2016 to March 2018. Patient selection criteria were as follows: adult classification type B, age less than 75 years, using Fitmore stem, computer tomography images taken preoperatively and within 2 weeks after TG. Patients with previous femoral osteotomy were excluded. We compared two groups of patients, one without subsidence and the other with subsidence, in which patients with subsidence of 2 mm or more on simple radiographs at 1 month postoperatively were considered to have subsidence. 10 patients were in the subsidence group with a mean age of 59.1 years and a mean BMI of 24.5. 5 patients were in the subsidence group with a mean age of 61.2 years and a mean BMI of 22.6. The origin of the coordinate was the center of the femoral head. The reference axis was the femoral medullar axis due to 6 cm distal to the apex of the left trochanter. We define this axis as the proximal femoral medullar axis and the superior inferior axis. The medial lateral axis is the transepicondylar axis. We define this coordinate system consisting of the above axis as the proximal femoral medullary axis coordinate system. The reference axis of the stem is shown on the left. The rotation of the stem is shown on the right. Using postoperative CT, a contact site was defined as a CT value of 600 or greater as the contact area between the femur and the stem. The Green classification zone 1 to 14 was used to evaluate the contact site between the stem and the femur three-dimensionally. The pre- and postoperative femur models were subject to 3D registration to reproduce the postoperative femur stem model with an artifact accurately. Elastic analysis was used for the analysis. The CT values of each mesh was compounded to BMD using the standard calibration curve. Young's models was calculated from the BMD of each mesh based on the prediction equation of Morgan et al. We used a setting condition of stair climbing, which is high rotation torque to the stem, and the one-leg standing condition, which is low rotation torque to the stem. The load was calculated in relation to the patient's weight. For example, when a patient weighing 50 kg stood on one leg, a load of 1,384 Newton was applied to the prosthetic head. Tensile forces of 692 Newton, 533 Newton, and 685 Newton were applied to the greater trochanter, lesser trochanter, and gluteal tuberosity respectively. The distal end of the femur was fully constrained. The friction coefficients of the contact surface between the femur and the stem were as follows: 0.64 and 0.49 for the proximal and distal correlated portion of the stem. Micromotion was defined as the displacement difference as the element nodes of the contact surface between the femur and the stem. Outcome measure was the stem alignment, the site of contact between the stem and the femur, and the micromotion by finite element analysis. Statistics were performed using monthly when U-test at a significant level of p equals 0.05. All data are presented as mean plus minus standard deviation. Results: the mean Barre's flexion and antibarrier angle in the no-subsidence group were 1.4 degrees, 6.3 degrees, and 28.9 degrees respectively, while the mean Barre's flexion and antibarrier in the subsidence group were 1.1 degrees, 3.2 degrees, and 37.5 degrees respectively. There were significant differences between the two groups in flexion. The contact site with the femur were mainly in zones 3, 7, and 12 in no-subside group, and mainly in zones 2, 5, and 7 in the subside group. Micromotion averaged 29.9 micrometer in the one-leg standing position and 37.4 micrometer in step climbing in the no-subside group. On the other hand, the mean value for the group with subsides were 76.8 micrometer for one-leg standing and 63.5 micrometer for step climbing, showing a significant difference between the two groups in both one-leg standing and step climbing. Discussion regarding the relation between the Barre's angle and contact area in Zone 1 to Zone 7. In the no-subsidence group, the stem and the femur were in contact mainly in Zone 3 and Zone 7. The mean value was the mild Barre's angle, while in no-subsidence group, the stem and the femur were in contact mainly in Zone 2, Zone 5, and Zone 7. The mean value was mild Barre's angle. From the above, a mildly Barre's insulation may be more stable, in which the stem makes contact with the femur in zones 3 and 7. Regarding the relation between the flexion extension angle and the contact area in Zone 8 to Zone 14, in the no-subsidence group, the stem and the femur were in contact mainly in Zone 9 and Zone 12, while in no-subsidence group, the stem and the femur were in no contact in most cases. The flexion angle of the no-subsidence group was significantly greater than that of the subsidence group. From the above, flexion insulation in which the stem contacts the anterior and posterior femur is considered more stable. Micromotion was significantly greater in the subsidence group in both one-leg standing and step climbing, and higher micromotion was distributed throughout the stem. In addition, the CT used for evaluation was within 2 weeks after surgery. Therefore, in the subsidence group, micromotion was large and extended over the entire area, resulting in subsidence after 1 to 2 weeks post-operatively. The study conditions and the CT evaluation used in this study are reasonable. Conclusion: the stability of the stem after total hip arthroplasty was evaluated three-dimensionally using stem alignment, stem to femur contact site, and finite element micromotion. The fitmost stem may have better initial fixation when installed in a mildly reversed position, such as in contact with Zone 3 and Zone 7, and in a flexed position, such as when placed in contact with anterior-posterior femur. In the cases of subsidence, micromotion was large and distributed over the entire area, suggesting that the generated micromotion caused the subsidence. Therefore, the setting and the CT used for evaluation in this study was appropriate.